Welcome everyone to Dental XP. Welcome to this Wednesday webinar. Happy 4th of July for those of you that are watching from the United States. My name is Andrea Mastrosagnini. I'm working with my brother Alessandro, my older brother Alessandro. And today's topic is CAD-CAM technologies. And how CAD-CAM technologies, especially nowadays, are helping us in order to restore cases on natural dentition and implants. As I was saying, I'm gonna give you this lecture in English for the English part of this site. But if you wanna see the Italian version of the website, just go on the main page of this of Dental XP and click on the Italian flags, and you're gonna have Alessandro and Luca that are gonna speak to you in Italian. So let's start. And what we did today is to divide this lecture in three parts. At the beginning, we are going to introduce a little bit exactly what does CAD-CAM mean exactly. So we're going to give you a brief introduction. Then in the second part, in the second section of this webinar, that is going to be the main part. I'm going to present you a case that came in our office in 2008, and you're going to see exactly step by step our protocol that we try to standardize it for every patient that enters in our office. And at the end, I'm gonna give you a brief conclusion, and I'm gonna try to give you some take-home messages. So before starting, on the right side, this is our team. Is Alessandro on the left. In the middle, there is Luca, that is working with Alessandro since 1998, and on the right side, there is me. And I want to thanks all the Dental XP team, Maurice, Henry, and Hedy, and also Tyler and Pana for the support that gave us to prepare this webinar. And I want to remember you, all of you, this first Dental XP Global Symposium meeting that is gonna be in a very nice venue in Vegas next year from the 7th to the 9th of February in 2013. So I invited you, all of you guys, to join us. As I was saying, let's start and let's introduce our topic. So exactly what I was saying at the beginning is that nowadays, modern dentistry is looking for new technologies in order to improve, to have better outcomes in restorative aesthetics, and to have also not only aesthetics but to have also a higher precision in every single detail that we do, and also to try to increase the mechanical strength of the material that we use. And the CAD-CAM technology was imported from the world of engineering, and this gave us the possibility to use different kinds of material, different dental materials, including zirconia, that simplified the clinical and technical procedures. And we know there are a lot of CAD-CAM systems that are currently available, and right now more than 95% of all the objects that are used daily are produced by CAD-CAM systems. So exactly what does CAD and CAB mean exactly? Basically, with the CAD part, we have the possibility to design an object guided by the computer, and once we did that with the CAM part, we can we can actually have this master model, and everything was starting, the final part of our final restoration was starting from a prosthodontic project that was done by the technician. And from that, CAD-CAM technology bring it in dentistry. As we see, the first two steps, especially in this procedure, didn't change. There is always an impression, and then we see that there is one similarity with the traditional procedure, that is the prosthodontic project that doesn't change, that is always done by the technician that has to put his experience, his background in do this project, and then from there we can he can put his background, his knowledge also with the CAD, so with the new technology, and designing the framework designing exactly what we want in our mouth. And from that, there is the CAM part, that is basically what he designed at the computer. We can try them in the mouth, and if everything fits perfectly, we can go to our final restoration. So this is basically what we're gonna see today. This is the procedure that we're gonna see today in our presentation. And so in 2008, this is our patient that entered in our office, 58 years old, an engineer, and it was like his chief complaint. He was really worried because he had a high mobility of the upper arch, and he was worried because he couldn't chew the food correctly, couldn't speak correctly. He was in pain. He had a central incisor that when he was occluding, it was giving him pain, and he was afraid to lose all the upper teeth. His attitude was like positive, was receptive, was cooperating. He was willing to try to solve this problem, and of course, his need was to improve first of all the chewing function that was not the same as before. Has an high mobility, and the mandible slips forward when the mouth was closed, and he was losing teeth throughout the years, and he referred to us that he was like brushing his teeth once a day. So as we always do in our protocol, we try to collect all the information, and we start taking picture of the face, of the smile, and intraoral pictures. So basically we are going to evaluate our patient, every patient that enters in our office, from the macroaesthetic point of view, so facial analysis, to a microaesthetic point of view, so intraoral pictures, intraoral analysis. So we're going to evaluate the face, we're going to evaluate the smile, and we are going to evaluate the teeth. And as I was saying, his chief complaint was like he was worried because he couldn't chew anymore, and his upper teeth were moving, and he was afraid to remain without teeth anytime soon. So starting with our protocol, facial analysis, we always see the facial midline, that in this case was symmetric. We evaluate the dental midline that was inclined towards left about 2 millimeters. His bipupillar line was parallel to the horizon. From this picture we can also evaluate his smile in the face. So the superior occlusal plane was inclined towards right, and the inferior one was slightly inclined toward left. The superior lips were thin, and the inferior lips were average. And of course all of this information are shared with Luca, that also for him are important because he has to help us on the diagnostic workup, and we are going to see it a little bit further. The profile, so the facial analysis is not always like the front picture, but it's also the profile picture, that we can achieve other information from this. We can evaluate like the three thirds. We evaluate the profile, that is concave, the rickets superior aesthetic line that is 5 millimeter, and the inferior one that is 3. And we can also evaluate the nasolabial angle, that is around 100 degrees. And all of this information are written on a chart, on a static chart, and on a lab chart that we have in our office, that is done for every single kind of this patient. And then we send this chart to Luca, so he can use this information to help us on try to give a correct treatment plan to this patient, correct hypothesis of treatment plan. So passing through a dental facial analysis, we can evaluate the smile line, that is average. We evaluate the incisor superior plane, that as we can see is flat and is distant from the inferior lip. You see the buccal hazel that are wide, left and right, also because he was missing all the teeth. And the width of the smile, that it was basically around 12 teeth. Going to a more microaesthetic point of view, we can evaluate the teeth. Exactly, we can evaluate what our patient has inside his mouth. And again, we can evaluate that the superior dental midline does not match with the inferior one. We can see exactly what he has in his mouth. So on the superior arch, he has this PFM crowns from canine to canine, and he doesn't have posterior teeth. As I said at the beginning, he was wearing like a partial removable prosthesis that he was not fitting anymore, so he was not using it anymore. And in the inferior arch, he has a composite splint with 6 incisor, and there is no posterior teeth again apart from one molar in the bottom left side. It's also important to evaluate the biotype that was thin, and we can see especially in the both in the upper and in the lower arch there was like multiple recession. On tooth number 44 there was a mucogingival problem, and also if we evaluate also the gingival margins, of course we see that we don't have like symmetry on this. So also these are information that are important to write in the chart and to try to do an hypothesis of treatment plan. But first we still have to collect information, so functional information also, like we evaluate which class relation is our patient, so is an Angles class 3, left and right canine, which kind of Kennedy class we are in front, so in the superior arch we are in front of a first class, in the inferior arch of on the second of in the inferior arch we have a class 2 and a class 3 on the two different sides, and as we can see we have a lot of deposit of plaque and tartar, so we have also to enter in our preliminary treatment plan that we are going to see. And as I was saying, also important apart from this like collecting of this information, we have to add also functional information. So we have to evaluate our patient in maximal intercuspation, we have to evaluate our patient in centric relation, because we have to see if we have the possibility to reestablish a correct occlusion to this patient. So we see that talking about the articulation, there was no pain, his mouth opening was normal. As we see really clear in this picture, the centric relation does not coincide with the maximal intercuspation. We have an anterior is a 3 mm reverse over bite and 1.5 mm reverse over jet, and we have a reverse light laterality between 13 and 44, and a reverse left laterality between 23 and 33. Sorry. So again, we wrote this in our chart. Phonetic analysis, another important step. So we evaluated the S sound that gives us like the vertical mandibular movement, and we can evaluate the free space, and we can see that there is basically no free space available here. With the E sound, we evaluated the space in between the lips of the central incisor, that is basically the 50%. Then with the F sound, we can see where is the incisal edge of the central incisor, and we can see that in this case it's inside the lips for sure. And with the M, we can that is basically the rest position, we can evaluate the space exposed, that in this case is about 4 mm. So always in the first visit, after all these pictures, after we do also a quick periodontal screening and a quick periodontal screening record that also goes to our charts. And in this case, we see apart from on the upper right and upper left that there was no teeth, all other sides are 4. And we know that the periodontal screening record goes to 1 to 4, and 4 is the worst number that we can give to, is the worst value that we can give. And especially in the lower arch, there was furcation involvement, there were recessions. So again, another information. After that, we put our patient in what we call a preliminary treatment plan, in where we are keeping on collecting information in order to give an hypothesis of treatment plan of the end of this of this preliminary treatment plan, that is composed by a full mouth X-rays, a more accurate periodontal evaluation, a prophylaxis therapy. So we explain to the patient that he has to help us also at home with like more dental care. We do 1 or 2 sessions of scaling and replaning. We evaluate the study model on an articulator, And at the end, we do an aesthetic analysis, because function and aesthetic has always to go in pair. One without the other cannot be possible. So we see our initial periodontal evaluation before the scaling and replaning. So we evaluate all the sites in where we have bleeding. We evaluate where and how are the pockets, and we evaluate all the sites with plaque. X-rays evaluation. On the left side, you see an orthopanto or an orthopanto evaluation that the patient brought to us. And on the right side, you see a full mouth X-rays evaluation. That is what we prefer, because it's important to do diagnosis. We are more precise with the full mouth X-rays evaluation than only with the orthopanto. But of course, if the patient brings it to you, is also a good information to achieve. And from that, we can see that in the superior arch, we have an advanced horizontal and vertical bone resorption. And in the posterior area, we can evaluate we can evaluate the quantity of bone, and we can see that there is basically presence of basal bone with also sinus pneumatization. So again, we write this on our chart and we start to think, we collect this. In the inferior arch, we have a mailing horizontal bone resorption and forcation involvement of the left molar, number 47. And in the posterior areas, we have the presence of a good quantity of vertical bone above the alveolar nerve. And also this is a good information that can think us of implant therapy. So then we do the scaling replaning, the prophylaxis of the patient. We explain how to have a better dental care at home, and we re-evaluate the patient. We see again how many sites are bleeding, and you can see that are much less than at the beginning. We see how are really the pocket anatomy in this case, because we have less inflammation of the tissue, so we can be more precise, and we can evaluate where there is still plaque. And of course, it was not easy, especially because of the splinting in the inferior arch. It was not easy for him to keep clean, because it was there were a lot of undercuts, so it was not easy. Also, if he was putting himself into it, was not easy to keep his work clean. Then we have the mounted cast evaluation. That is important for us, but is important also for Luca, for our technician, that also him starts to achieve information. We evaluate them, of course, mounted in articulator, and we see that there are 2 millimeters discrepancy between the centric relation and the maximum intercuspation. If we take the models in our hand, we can see that they are non-stable. We have an accentuated left speed curve, and we have wide posterior interarchy space, because of course there are no teeth, so there is this wide spaces that has to be filled up in the final restoration. We can see that there is a mesio inclination of number 47, and there is an inadequate space for restoration of number 45. And we start to think, we say that we saw at the beginning that is a third class, is an angle class free patient, and we can start evaluate if there is the possibility to prosthetic compensate this reverse bite that this patient has. So, as I was saying before, all the information that we achieve until now are not just information for us, but are information also for our technician, that collect all of this, take a look at the pictures and start to discuss with us how can we give this patient an hypothesis of treatment plan. And right now, new technologies does not mean only CAD and CAM, but can means also that we can work on the computer and we can explain to our patient what are our goals and what we can do for him. And especially by visualizing what we are trying to explain to him, not only just this patient, but all the patient can enter more in compliance with us and can understand more what we are talking about. So we see the same picture that we see at the beginning, the facial analysis. We can see the midline, the occlusal plane, and we can evaluate it with this method that was introduced by Christian Kochman of the digital smile design. We can actually do a digital aesthetic analysis. We can evaluate our patient the lips, we can evaluate the teeth, we can evaluate the axis of these teeth, and we can see with and without the picture what we can improve, and we can do an hypothesis digitally of treatment plan. We can see if everything is correct. We can try to put the teeth in the correct position, with the correct occlusal plane, with the correct midline, with the correct axis, and we can try to show this to the patient to make him understand what we can do for him. And we can also try to show him what can we potentially do for him. And in this case, when patients see themselves in the screen, and see, especially on the picture on the left side, what we can do for them, what potentially we can do for them, they are also more into the treatment plan. They are also like more compliant with us, and they are like more positive. They are more receptive. So I think it's a very important tools that nowadays we have. So new technology means like, yes, zirconia, milling center, CAD, CAM, but it also means like computers, digital static analysis. That also this, from my point of view, it's like a new technology that can help us and can help also our patient. Because from that, Luca can do a diagnostic workshop that is going to help us, is going to help me and Alessandro when we are going to expose our hypothesis of treatment plan to our patient. What can we really do for him? And he can see what are our ideas, what are our hypotheses of work. Because this is what we want. We want to put our patient in the middle of the treatment plan, and from there start. And as I was saying before, patient in the middle of our treatment plan. In this case, we are prosthodontics, so we have a key role to like manage all the disciplines of dentistry, starting from the hygiene, passing through comprehensive care, endodontics if there is need, orthodontics, perio and implant surgery, if there is need, maxillofacial surgery, and also the cooperation with the technician that you see that starts from the really beginning of this project. And with all of this, the patient is always in between, is always in the middle of our treatment plan. And I think that when a patient understands this, is also more willing to help us of having an aesthetic and functional success. So again, after that we discuss with Luca, we collect either more information. We start to see which teeth we can save, which teeth are hopeless, which teeth are questionable, and which teeth are good. And also this is important. For example, on the right side of this patient mouth, was also only this premolar that was a little bit weak from the periodontal point of view, but like we can think that we can save it like with like a periodontal surgery. So as you can see here, we take pictures, X-rays, probing evaluation, bleeding evaluation, recession evaluation. Same thing in the front area of the patient. We evaluate the recession, we evaluate again if there are any probings, we evaluate if there is bleeding, and we can see for us in this hypothesis of treatment plan that we are doing which teeth are questionable, which teeth are hopeless, and which teeth we can save. And we write this on our chart. And you can see that in the upper arch, unfortunately, due to like a lot of like periodontal and endodontics problem, we cannot save any of these teeth. While in the lower arch we can save some of the teeth of this patient, and it's always important to show also this to the patient that we can save some of these teeth. And on the left side of this patient, again we evaluate like if there are like any forcation involvement, for example of the molar, that unfortunately we cannot save. And we can see again we basically write which teeth are hopeless, which teeth are questionable, and which teeth are still good that we can use. Another information is the CT scan evaluation, because we saw that we are gonna lose all the upper arch teeth, so we have to evaluate where is the bone and how is the bone, and we can see that in this case all the bone is in the is in the anterior area. In the posterior area, we know that if we want to place some implant, we have to do like some more invasive techniques like sinus lift in both sides. And so we try to do an hypothesis of treatment plan based on the CT scan, and we try to be less invasive as possible, because the important of the, for our point of view, is important that the quality of the life of the patient is good. Not only at not only at the end of the treatment plan, but also in the meantime of the treatment plan. So we always try to be less invasive as possible. And after that we collect all the information. After that we collect all this information. We always do a critical evaluation of our clinical situation, and so that is basically a resume of what we see until now. So we know that we have a 50 years old patient with elevated need of functional rehabilitation. We have a thin biotype with chronic generalized periodontitis that is advanced in the upper arch and moderate in the lower. We have high teeth mobility of the upper PFM bridge, and we have poor bone quantity in the upper posterior area. Average myline is a third class, potentially that we can prosthetically counter available in first class, and we know that from the beginning that the patient does not accept any intermediate removable prosthesis. So again, we have to try to collect all this information, evaluate them, looking to which teeth are we can save, which teeth we cannot save, and we can look also which kind of teeth are let's say make sense to save, because for example the molar on the left side, we evaluate the pros, the advantage, the benefits, and the limitation for taking this teeth in the mouth, and if we see that does not make a lot of sense to save these teeth, we can like strategically take it out. A lot of my time, a lot of time of this lecture to explain to you all the data that we collect and how we can use it. Because after that we collect all this data, we can like number 14, let's call it like this. We're gonna do an osteotome technique, and in the lower arch we're gonna place the two implant in the back mandible, in the back area, and if there is the possibility, it's gonna like be in occlusion with the temporary in the upper arch. So it's gonna facilitate our work, and it's gonna, I think, improve the quality of the life of our patient, that is not gonna work out with a denture, and is gonna work out already with the correct occlusal plane, that I think is really important since the beginning. After that, we're waiting for the osseointegration of the implant. While we are doing this, we are gonna work on the inferior arch, like with periodontal surgery, since we see that there were a lot of like small pockets that we need to solve. So we need to manage with the periodontal with an osteoresective surgery. We align the temp, and after that all the tissue are maturing and are matured, we can go through the final restoration, and we can take the final impression, do our framework train, do our bisbake, and finalize the case on zirconia oxide. And also we see, since that there was a lot of also vertical dimension, also vertical space to cover, there was a lot of space to cover. In our hypothesis of treatment plan, there is also like a pink zirconia oxide, a pink like ceramic, in order like to not to have like teeth that are too long at the end, so they are not aesthetic. So we're gonna mix with white and pink aesthetic to have like a better aesthetic result. So once we did that, we expose this to our patient. If the patient accepts, we start our rehabilitation. And as I was saying, the patient is in the middle of our treatment plan, and us as prosthodontics, we have like to evaluate every steps of our procedure, and we have like different goals that we have to achieve of every disciplines of that are involved in this treatment plan. So even if we have just one tooth that are gonna go for that will need an endo treatment, we have to have endoconservative goals. So we have to be also for that we have to be as much as conservative as possible, trying to give the best support to the tooth crown structure, and again we are trying to be as less as invasive as possible. So so only if there was like really the need, only if the teeth that was only if there was really the need of doing the root canal of these teeth, we're gonna do it. We are, even with our preparation, we're gonna try to be as conservative as possible in order not to do too many root canals to this patient. So to try also on that point of view to be more conservative as possible. So our prosthetic goals are, of course, we need to restore the two arches simultaneously to establish an adequate function and aesthetic to our patient. And as I was saying before, we are gonna use feather edge finishing line to conserve tooth structure and avoid root canals. The periodontal goals, as we see, especially in the inferior arch, we're going to eliminate the periodontal pockets and bring the probing depth back again in an healthy range, so we can restore these teeth in this way. And of course, the implant surgery goals are to reestablish the lost teeth. What we're going to use for this patient is a technique that we are routinely using since like 6 years. That is called one model technique. That was also like is a technique that was taken from a former president of the Italian Academy of Prosthodontics, that is Leonello Biscaro. That this technique basically is divided in 3 phases: the pre-surgical phase, a surgical prosthetic phase, and the final phase. And as you can see, the clinical and the technical steps are always like going once next to each other. And it's called one model technique because the peculiarity of this technique is that we're going to have one model from the beginning till the end. So we're going to have like all the volume, all the information that we collect at the beginning that are going to help us and are going to help Luca in defining the right spaces, the right volume, and the right proportion of the final restoration. And we're going to see it step by step. So in order to do that, we need to give to Luca some information. We need to give to Luca information of like vertical dimension of like in order that he can start working on that, and he can start doing this like walks up that is gonna from where is gonna came out like the surgical stent, the radiological stent, but also from the same model we're gonna have like also the first temporary, and from that we're gonna have the final restoration. So we see that we are basically at the same point. What always like really amazed Luca is that there are a lot of like work, a lot of information that we need to collect in order to start to restore a case. Because as you can see, this is basically the diagnostic walks-up, the picture that you saw like at the beginning of our case. And until now we just collect information that are gonna help us on like finalize the case. And from this diagnostic walks-up, as I was saying, Luca is gonna build a transfer plate that we're gonna see more in details what it is. That is like one of the keys of the one model technique. He's gonna do the temporary. He's gonna do the stents just based of this diagnostic workup. So you can see how important is to arrive at this point with the correct diagnostic workup. So how important is to collect a lot of data, not to make mistake while we are doing the treatment plan. And again, Luca can start building up the lower temporary, that is like in occlusion with the upper diagnostic workup, from where he can build, as I was saying before, the surgical stent and the transfer plate that will help us in the surgery. And again, surgical plan. We have the possibility to have the orthopanto, so we are using it, and we are doing our project first on the X-rays, then in the mouth. So we're gonna place on the right side of the patient 3 axial implants, and on the left side like 1 tilted and 2 axial implants, and then we are gonna put like 2 implants in the back posterior area of the mandible and extract all the other teeth. So surgical phase, you see here like left side of the patient, poster-static sites, non-poster-static sites. So also a surgery that has to be planned carefully, and also like the biological aspect of this has to be really taken in consideration, where to place the head of the implants, because also this from a prosthetic point of view, it's really important. And for the tilted implant, it's important to evaluate and to do a small opening of the sinus in order to have to be anatomically driven on the placement of the implant, of the tilted implant. So you see how many details are involved surgically and prosthetically in this kind of restoration. Then is always important the surgical stent that help us on the correct prosthetic position of our implants. And it's important, also you see on the left side, osteotomy in order to compact the bone and to achieve the better primary stability that of course we're gonna do in immediate. So you see here, after the placement of the 6 implants, you see that we're gonna take out the fixture mouth of the implants. We're gonna place conical abutments, and this abutment we're gonna not take it out never again, hopefully. We're gonna because from there the temporary is gonna go screwed in over there, and it can be just a small detail, but not removing the abutment is also important to have less resorption, because we saw from the literature that every time that we remove an abutment, we create a sort of trauma to the adhesion to the bone, and we can have resorption of this bone. So also this one abutment one time is another detail that we should think about it. So again, in our one model technique, I was saying that it's really important. One of the keys is a transfer plate. What is a transfer plate? It's something that is built by the technician based on our impression of our patient. And if you saw it before, I'm gonna go back a little bit of one slide. If you saw, we are not opening, we're not elevating the flaps, especially in the palatal point of view. We are trying to be as much as conservative as possible. First, also for the morbidity for the patient, but also because this transfer plate that we're gonna place is gonna be placed and is gonna be is gonna be placed in the palatal mucosa. So if the palatal mucosa is not elevated, we are more precise, because of course one of the weak points of this technique is that the transfer plate is built on stone on the model, but in the mouth we have the mucosa that is not that hard is the stone. And you see here that this is a protocol that we are using from 6 years, and that is also a part of is a topic of an article that we did with Kristen Stappert, with Davide Romeo, and with Leon Pariente, that are also like my friends from NYU. And we submitted also we submitted this article to the clinical implant dentistry and related research. And you see here how we like take the position of the implant. We put like this impression coping, we solidize them with an ortho wire. In this case we are using patent resin. Right now we are using like a composite resin from 3M that is called ProTemp, that has less shrinkage of this material. And on the upper right side, next to the title, that is transfer plate, you can see our transfer plate. And on the picture on the right side, you see our like how can I say, our like try. We have like not only the transfer plate, but we do also like a control transfer plate that we're gonna give to Luca, and is gonna control in the model if we take the correct position of the implant. And we are gonna see how in a few minutes. Then we are gonna suture the patient. You see here that the suture are not tied that much because the patient is gonna go home for 48 hours, and on the Monday we're gonna remove the suture and place the finer and place the temporary on it, so we don't need to tighten it that much, because if we tighten that much the patient is gonna have pain while we're gonna screw the temporary inside the conical abutment, because the mucosa will shrink too much. And you see here on the right side the transfer plate outside of the mouth, and you see that we took the final implant position, and we are going to give it to Luca. So it's important also to evaluate from here on the left picture the importance of having keratinized tissue on the vestibular side, that we know that is always important to have. And here we see, now we are like back in the lab. This is exactly what Luca received from us the day of the surgery. On the left side there is the transfer plate, and in the middle you see how this transfer plate is placed in our model, and how Luca has the final implant position on our model. And as I was saying before, this is the picture that I was showing you before. There is this control transfer plate that Luca placed in his model, and while screwing in the analogs, is gonna see if we took the correct position of the implant. So from there he can start working on the first temporary. And you see here he has already all the information needed, because we took a lot, because we collect a lot of information before doing the surgery. So Luca doesn't start from scratch. He has already the correct volume, he has already the correct spaces, he has already the correct aesthetic tool, aesthetic analysis that help him to build this first temporary. He has already the lower temporary that he built it before, and he put them in occlusion. And 48 hours after, when the patient comes to our office again, we prepare with a knife edge finishing line the tooth, in order to be more conservative, in order to have more tooth support. We do, if there is the need, mucogingival surgery and osteo resective surgery on tooth number 44 that we saw from our treatment plan evaluation that needed. So since we try to do as much as we can in one step, we are gonna take care also of this. And then we have the temporary on the upper arch and on the lower arch, and we are gonna reline the lower arch in occlusion with the upper one. And this makes our life much easier, but makes also our patient life much better, because we are not giving him a removable denture, and we give him like something that can work, that can permit him to work out from our office only 48 hours from the surgery, And you can see here there is no swelling because of we see that using the caution sedation approach, also the follow-up of the surgery is less traumatic for them. So again, another small detail that can help the quality of life of our patient inside in the middle of the treatment plan. And from there, this is our start, our start point for our final restoration. From there, we're gonna start to evaluate everything that we can make it better, everything that we should change, and from there we can start doing really our final prosthodontic project. After that, the tissue are matured. After like 2 or 3 months from our surgery, we can do the periodontal surgery on the lower arch that we planned. And you see here we always use Vicryl sutures 6-0. Also, this is an important thing. We always try to be less invasive as possible with the surgery. We try to be as clean as possible. We polish really carefully our provisional in order to have a good maturation of our tissue. Why we did this surgery, I was saying, I said it in the treatment plan at the beginning, because we evaluated there were a lot of probing depth that could have been treated with an osteoreceptive surgery. So we did it. We saw the patient's needs, and this is important because maybe 10 years ago we would have done 4 or 5 surgical approach. And this, for the morbidity of the patient, for the quality of the life of the patient, is not that good. It's better to have 2 surgical steps, and the patient is happier with this, and we are happier too. The lower impression, you can see here the upper arch, how the tissue are healing. You see that we always solidarize all the impression coping with patent resin and with an ortho wire in order to give a skeleton, skeleton of to the patent resin, not to go all the way. And here you can see the maturation of the tissue in the lower arch. And from here we can take the final impression, and from here is Luca that starts literally being the key of this rehabilitation, because with this background, with this background, and with the new technology that we're gonna see in a little bit, we can be more aesthetic, we can be more precise, we can be more functional. So you see here we have our model, our master model, that is always the same, mounted in articulation in centric relation. We are gonna take this wax up. We're gonna take with the wax we're gonna do a sort of we're gonna give to Luca aesthetic information, prosthetic information. From there he's gonna do an hypothesis of prosthodontic project based on the lower temporary that he knows that is always the same, and you see the diagnostic walks up, how important it is. He's gonna do this hypothesis of upper arch project that we're gonna try in the mouth once Luca thinks that all the details are okay, the static details, the occlusal details are good. And you see we're gonna do it in the mouth of the patient. We're gonna take pictures, we're gonna make him smile, we're gonna evaluate the smile of the smile of the patient in his entire face. We're gonna do the macrostatic and the microstatic evaluation, the smile line evaluation, the occlusal plane evaluation. Luca is gonna come to our office to see this. He's gonna take a picture, he's gonna bring his picture to his laptop, and he's gonna start building, he's gonna start doing his prosthodontic project from here. So you see, now he has all our information. He's gonna correct all the occlusal things that he thinks needs to be correct, and from there he can put his background, his knowledge to our service, and you can see from an inside perspective of this prosthodontic project, you can see like always from an inside perspective, like all the occlusion, all the function that has to be studied for this. And from there we can do like he can do an occlusal anatomy template, so he can have them always from here till the end. He doesn't have to redo them again. He's gonna do this template, and from there he's gonna start his project that also is gonna be also digital, and we're gonna see why. Of course, it's not like it's like natural dentition, but it's also like implants. So we always want like right now in our protocol, we want to have, yes, zirconia abutment, but not full zirconia abutment. We want to have, we think that right now the most secure thing is to have like zirconia abutment, but with the titanium core. And you see that also here it's important the way you put the core and the zirconia together. You basically like treat the zirconia and the titanium core with a particular procedure. You're gonna fix them. You're gonna like attach them with an adhesive protocol. After that, you treated them with Rockatech. So it's important. Like details are important. You're gonna take out the voids, and at the end you're gonna refine your abutment. And also this, it's an important protocol steps that is not that difficult, but has to be done in order like to have like less mistake, to have a better prognosis, to have a better follow-up at the end of the case. And so on top of this, we're gonna build is gonna build the framework. And right now the literature and his knowledge, his background knowledge, thinks that is better using this kind of material that is zirconia, having anatomically driven framework design. And this can be done thanks to Luca, thanks to the digital dentistry that we're gonna see it, but also thanks to all the information that we collect before from the prosthodontic project that we did before, because from there he has all the correct volume, he has all the correct spaces to see how much he can do, how much he can like how much he can build this framework up in order like not to have like an incorrect thickness of the final material that can end like in an insuccess, can end up in a chipping, can end up in a fracture. So also this is a very important part of the treatment plan. And as I was saying before, not only like the traditional approach, so not only like how much is the knowledge of our technician, it's important, but it's important like that right now, nowadays we can use like new dental technologies. We can use like new scanner that help him to do what he wants in more details and being more precise. Because right now we have like the last generation the last generation scanners, as you can see here. It's written it's written they have a precision of 8 micron of volume. That means that it's not like a precision of 8 micron on a single element, but it's a precision of 8 micron on a complete arch. So you can have a full arch, and you have like a precision that is based on of 8 micron discrepancy. So from here you can see on the right side on this ZFX project scanner, you can basically project your final rehabilitation at the computer. You can our technician can put their knowledge of traditional approach into the dental technology, and they can be more precise because they can do something that that before the machines could have not been, they can do something in a more precise way. And you see all the care of the details that we have, and it's important to be also more precise in that, because also the precision is a detail that is really important on a long-term prognosis of our works. And you see here that you can acquire the data with our scanner. You can basically like acquire like the full model. You can evaluate the implant position and the implant inclination thanks to this match holder that are done especially for the dental lab. And you can see that you can superimpose this picture, you can sectionate them, you can have like all the model, you can have only the implants, you can have only, as you can see on the right side, you can evaluate only the gingival tissue. So basically you can evaluate exactly what you want, and you can do trials, you can replace them, you can start from scratch if you think that you made a mistake. So you have much more control in this way. And you see here that once that our prosthodontic project that has to be first done in the mouth, has to be first tried in the mouth as we did, it can be scanned, and you see here on the left side it can be superimposed with like the implant position, implant inclination, and you can see here that you can evaluate from any perspective, from any point of view, so you can control and you can measure them more times, not just once, but you can control them more than once, and so you can be more precise, because then you're gonna, after the cut part, you're gonna send everything to the cam that is really precise. And here you can evaluate, you see the implant position, but then you can evaluate the implant inclination, so you can evaluate where it's gonna come out on the final restoration. If you want to do a screw retain restoration, or if you want to do a cement retain restoration, you can evaluate where it's gonna come out the all of your of the implants. And you can like do some trials, you can see if you have enough thickness, you can superimpose all the project, you can superimpose like the framework, you can actually see through, because you can see from this picture that is really nice, you can put lower the opacity of the prosthodontic project, and you can see inside the actual inclination, and you can see where are they, and you can see how much thickness you have of each of these canal. So also these are information that before, without the new technologies, you could not have it. So there are other information that are important to have, especially for the technician. And here you can superimpose the framework, you can superimpose the project, so you can see how much thickness available you have. You can see always the actual inclination. You can actually choose what to do in every single of these steps, thanks to all these like characteristics that the ZFX software gives to you. And again, with other colors, you see basically what I was discussing before. You see the thickness, you see where are the holes of the screws are coming out. You can actually build them to make them more strength, because we know that where are the holes is a less strength point. So you can build them as you want in order to make them more resistant, and you can actually build them in zirconia. But this is made possible only thanks to the new technology. It's something that before you could have not done it, because there were like too many steps that has to be done in a correct way to be precise like you are right now. And again, with other colors, you see exactly on the model, the framework, where are the screws, how is the actual inclination of our implant, and different angulation, different point of views that are important, that are also like a sort of checkup, a final checkup before sending everything to the milling center. And this is the final project that Luca did for this case, and you can see here, you can actually evaluate inside on this right side picture, you can actually see where is the canal, so where is the voids of our framework and how much thickness you have. So you can basically do a lot of section of your work and see if everything is done correctly. So you can see how many information, how many tools the new technology are giving us, because the thickness are one of the keys to the success, to have a long-term prognosis of the new material. So it's really important, like, to combine the background, the experience of our technician with this new technology, with the possibility that these new technologies are giving us, in order to be more precise and in order to be more successful. So after that we did everything on the CAD, we go and we go to the milling center, we send everything to the milling center that is gonna mill our project. We are gonna use zirconia. In this case you see the project like with the zirconia pre-sinterized, and then you're gonna have your framework that with the of full zirconia. From there we are gonna start doing the try-in in the mouth. We are gonna start like paint this zirconia in order to have also an aesthetic success. And you're gonna start, you can color it, you have different colors of these that are available, and of course is the background experience of the technician that is gonna choose the correct colors for dentina, the correct colors for enamel, to make also a pleasant work from an aesthetic point of view. You see here again like the framework train on the model. From here we are gonna go more forward, and we're gonna always check it on the model, before on the model and then in the mouth of the patient, in where we are gonna evaluate not only like the fitting, so the passivity of this framework, but also like how it is in the mouth of the patient. And of course you see that it has been used like some static resin, so always the function is important, but we are not forgetting also the static part. So always important, aesthetic and function, that are going like steps by steps all together in our treatment plan. You see this is an occlusal point of view of our framework try-in. There is an occlusal trial with a resin jig, and then from there we start we send this back to Luca. That is gonna do his work, that is gonna finalize the case. There is of course the ceramic occlusal impression that came from the prosthodontic project that we saw before. So he start like putting his knowledge, is like his end work, let's call it like this, in our project, in our restoration, and he's gonna work on the occlusal point of view. After that we give him an occlusal registration, because remember also the occlusion is important. We are rehabilitating a case that was in a third class angle, and we're gonna bring him on a first class. So also the occlusal part has to be studied really carefully in order not to have an insuccess, in order not to have chipping later on the follow-ups. So you can see that you can do like some cross trying. Let's say you have an inferior bisbake and you still have the superior project try-in that is always the same that we saw before, and we can have like more control like this. So you can do this cross control always on a mounted cast models. Then you take then you take the framework that we already tried in the mouth, you put in the model, you evaluate your spaces, your thickness, and from there you start to choose the correct color, to choose like the correct morphology. You start like to paint, and you start to do the baking of the ceramic, and you start to do the layering of the ceramic. And of course you have to choose the correct color, because you want to have like a correct like you this. There is the first bake, then there is the second bake, and then you see this is the first bake, and from there you can like put again more layer on top. This is the second baking, and then you can have the bees bake. The bees bake, we are gonna try it in the mouth. You see here the bees bake that first has to be tried. Of course, Luca takes all the picture, also him in his lab, and it's important because as I didn't say one thing that I think is important before. Here in the baking you see that the layers are really, there is not a lot of thickness of the baking of the layer of the ceramic, because you have a better control of the contraction in between all the two bakes. And then we arrive to the bees bake. You see here the details. We are gonna try them in the mouth. We are gonna see if everything is working aesthetically, functionally, occlusally. We are gonna give the work back to Luca, that is gonna finalize the case. He's gonna evaluate again the occlusion if everything is correct, and he's gonna give us the work. Here is like a particular of the centric occlusion from behind, particularly of the dynamic movement of the final restoration in the model. And you see here the final Toronto bridge. And it's important also to use like a good quality zirconia, because right now there are a lot of zirconias available in the market, but of course you can have good aesthetics rehabilitation, good aesthetic result if you use like a quality zirconia, because not all the zirconia are the same, not all the zirconia are answering at the same way after the bakes, not all the zirconia has this lot of possibility, has this lot of colors. So it's important. It's another detail that we put in our treatment plan. So you see here the final restoration mounted in the mouth. This is the great work of Luca, and from there we can screw our work in. We can cement in the lower arch the work, and you see from where the patient started on the left side to how the patient arrived. And you see that everything is important. We evaluate also the spaces for the hygiene that we already did in the Bisbake train. We explain to the patient how to keep this clean, because of course also the follow-up maintenance is really important. We explain everything to the patient, and we evaluate how is from an occlusal aspect. I think we managed to have a nice success thanks to all the steps of our protocol. Here you see we always evaluate the smile of the patient in the face, in the entire face. We make him smile, so we see the occlusal plane. So you can see here a before and after of our work. And you see the timeline of the immediate protocol that permits us, like, if everything is done correctly, in 8-9 months to solve a case that was really complex. But if everything is followed like step by step, we can achieve nice success, we can have a good prognosis, and we can like make our patient happy in a small period of time. Just having like, it's important like to have like the less number of surgeries possible, to be as less invasive as possible. So here we have the 2 years follow-up. You can see especially in the lower arch. There is a little bit like small recession that is like normal, but I think that is a good picture for a 2 years follow-up. Everything is fine. The zirconia are perfect. There are no chippings. We control again the occlusal point of view. 3 years follow-up. It's important to see also the status of our implant. So basically, the more like the new technology, from my point of view, are gonna help us, but the new technology are not gonna do for us the work. I think that the clinician and the technician's professional background combined with the new technology gives the best possibility to achieve better aesthetic and functional results. So this is the key. We have to combine our professional background to the procedure are still of utmost importance in order to obtain satisfactory results. But we see that we saw that the CAD/CAM technology especially are evolving always faster and faster, and right now with the ZFX intrascanner we are able to take directly the scanner impression. So we have an intraoral scanner that is available right now, and we are developing faster and faster every day, and we are doing like for now like small cases, but I'm sure that in the future we can do like complex cases, because I think that new technologies and the CAD/CAM technologies are the future of dentistry. And you can see here what we can do. Like right now we are doing like we're just trying to do like small bridges, anterior crowns. We're not trying to push too much the system, but you see in this case of a central and a lateral incisor on natural dentition, but it's possible to do also on implants, that we can take an intraoral impression. We can go. It's not that pleasant. And I think that probably maybe in the next webinar we're going to discuss about this new intraoral scanner, and for sure we're going to discuss it, smile, and so the patient quality of life if everything is done correctly. So basically, differences, an important difference, that is the dental team. So thanking you for your attention. I want to thank you all, also our co-workers, our assistants of our office, of me and Alessandro's office, and also Luca's co-workers that helped us like to build us all these webinars, all these cases that without them we could have not been done. So thanking you for your attention. I hope to see you soon, and I hope to see you in Vegas.